Welcome to In the Clinic by Dr. Butch Levy. This month's episode is titled Autoimmune Disease, Systemic Lupus Erythematosus.
Good afternoon. This is Butch Levy, and I'm going to continue with topics on autoimmune disease. The primary one today will be SLE, systemic lupus erythematosus, and we're also going to talk about Sjogren syndrome. I thought about adding rheumatoid arthritis to this list, but what I find is that with rheumatoid arthritis, Chinese medicine is very limited in being able to control it, and if it's not controlled, there can be significant damage to joints rather quickly. So it appears that Western medicine is probably a better choice in terms of treatment. At some point, we could certainly return to some of the concepts of what might be supportive, but I think you'll see from this presentation that some of the aspects with lupus can also be used in terms of acupuncture related to rheumatoid arthritis. So we'll proceed on. I brought this forward just so you can look at the complexity of testing for people that have autoimmune disease. Anti-nuclear antibodies are antibodies that we see as a response immune-wise to different autoantibodies. And you can see that if an ANA screen is positive, then it moves to different tiers. It goes to tier 1, which will test certain types of antibodies, and you can see the names here, which I think having this chart also allows you order your own lab tests, or you see tests, what the specificity is of seeing things that can show you what might be very helpful in making a diagnosis. You can see that if we have the centromeres test on tier 3 here, it ends up being kind of crest syndrome. If it's tier 2, it runs into Sjogren's syndrome and systemic sclerosis and polymyositis. And a great number in tier 1 are multiple antibodies that you can see with lupus. I think the important aspect is to recognize that having a positive test doesn't necessarily mean that you have to have the disease. The antibody testing goes up exponentially, so it goes from 1 to 80 to 1 to 160 to 1 to 320, etc., 1 to usually like 640 and then 1,000. The tiers are such that the higher the number of antibodies, the greater the chances are that somebody has one of these diseases. It's not uncommon for me to see that patients have 1 to 80, sometimes 1 to 160. And I often will find that there are some underlying initiating causes, be it digestive with things like leaky gut and celiac and SIBO, or it can be related to some kind of lurking pathogen, either a virus or a bacteria, or even an environmental burden. And often these, because they stimulate the immune system so much, will ultimately lead the body down the pathway that it'll start reacting to some of its own tissues, and you start seeing these kind of problems start to develop. So intervention early is important. So obviously, in chronic autoimmune disease, again, immune dysregulation. We really don't know what causes it. We kind of just alluded to some of the factors that you would look for. Most commonly, you see the skin or the joints involved, but it's not uncommon to have CNS problems, seizures, cognitive issues, hematologic with changes in your bone marrow cells, the red cells, white cells. And a difficult one that becomes an issue is kidney involvement. So even though you feel that somebody has it, you have to kind of put the whole picture together. You might not have a really high ANA, or it might not be consistent with like a hemolytic anemia or a kidney problem, or you might not have a rash, as we see. But you have to follow certain criteria that, when they fit together, tend to clue you more towards thinking about that as a diagnosis. Again, as you can tell from this note, that it often is the exclusion of other problems. If you have hematologic issues, sometimes you have to do a bone marrow, do special testing. If it's kidney disease, sometimes you have to do a biopsy. So it can be a challenge, especially early on when things are just starting, where you had no history in the past and something's developed. You have to really look at what it is that you see. So an ANA with an anti-double strand or SM pattern leads you towards that, but you usually will have other features that make you think more of it. So things that go on, I think it's a 3 or 4 to 1 women, often non-Caucasian women, starting in often the 20s and 30s, but it can range up to the 50s and 60s. So there's a wide age range, primarily affecting women. And you can see there are a lot of different polymorphisms or mild changes in a locus on a gene that can be related, but not all of them are considered diagnostic of what's going on as a cause of lupus. So again, if you have a genetic predisposition, if you have something environmental which affects you epigenetically, or medication which can create problems resembling or being lupus related to the drug themselves, but you have to be suspicious. You might have a positive test with some abnormal labs in the right classification of 30 or 40-year-old woman. So you have to have experience often to kind of lead you toward that diagnosis. In the environment, some of the aspects you can see are EBV, our friend, that is related to multiple sclerosis, creating a mimicry or looking at something that resembles an organ system or something related antibody-wise, that the immune system starts seeing EBV and creates antibodies, but then because another normal part of our body, an organ system or a red or white blood cell, look similar, they create antibodies. So obviously you can see that things from the oil fields, solvents, hair dyes, heavy metals, pesticides, smoking are all things that can stimulate this autoimmune response. There can also be effects of hormones causing changes that can relate to the immune system becoming dysregulated. When you start seeing the inflammatory modulators like TNF-alpha drugs, tetracycline, minocycline, and sometimes even seizure drugs and sulfa can produce a positive ANA. But the question is how clinical are they? Is it the antibody, or is the antibody level high enough that it starts attacking our systems and starts causing disease? So what people are looking for are the classic fatigue, weight loss, fever, loss of appetite. And then you start seeing, the classic butterfly rash. You certainly can see, it's called discoid lupus, which is a rash that I've seen a number of times, especially in the scalp, that has to be often biopsied to tell you what it is. You can have joint pains, myalgias, kidney problems, and also start having problems with heart muscle function. So the American Rheumatology Association tells us that you have to have either the rash, you have major joints that aren't being destroyed by the inflammation, hemolytic anemia, low white and red cells, not uncommonly oral ulcers, mucosal ulcers are seen, and then you can see higher levels of involvement where you end up with damage to the kidneys that allows protein to leak, and you end up with generalized edema and renal failure. You can have protein in the urine. Then you can also have CNS problems with seizures and psychosis. And actually, I've had patients that I've seen every one of these distinct entities that have gone along with other points. So if you have a positive antibody test and you have 4 of these considerations, then you can say that more than likely it's lupus. So you can see here the types of problems that you can run into. A lot of people have, once they're diagnosed and they're on the right medications, they can have these intermittent flares where things get going. The medication tends to be amped up and the flare will often settle down, but people are maintained on drugs, often at a really consistent level, depending on the disease activity. But if you can keep it at a lower level that matches what the disease state in, it's the best way to go. You can also have specific organ patterns that have disease activity, such as severe renal disease. I have one patient that is healthy and does a lot, but is on an immunosuppressive drug because he has chronic kidney disease, but nothing else currently. And then you can have people that are diagnosed and their disease is quiet. They don't seem to have a lot of symptoms, but you know that it's there. And obviously, trying to look at what might be the triggers, as we talked about for initiating causes, about infection or environmental burden, to try to keep the pattern from accelerating. Usually people are put on prednisone overall for things, but immunosuppressive drugs are used not uncommonly, and they're most often used once the diagnosis. And if you're really sick, the prednisone will really help stabilize things pretty quickly. And from there, then a decision about what to use in terms of the types of immune drugs that work on different areas would be worthwhile and are looked at then. So in Chinese medicine, the concept would be that we have this chronic inflammatory problem, which we would see as yin deficient fire. We have severe, and I'm talking about not a little night sweat or a hot flush, but severe yin deficiency with toxic yang fire and wind. And this inflammation, this yang fire, can be extremely severe. Obviously, if it's damaging the kidneys and causing seizures and damaging your bone marrow, can be life-threatening and often requires heavy-duty drugs to control it if it's really acute, which adds to the whole problem of more kidney and liver yin depletion and damage. So it's can become a vicious cycle. So as we talked about earlier, what we're really looking to do is we can make a diagnosis, but we want to keep somebody stable because people live a long time if the inflammation is controlled. And I think that's important to remember, is that preventing people from moving out of a low range of illness to, exacerbations and flare-ups that are damaging their kidneys or their heart more is what we want to prevent.